the 2015 ISTH conference in Toronto behind us. I'm Thomas Baldrick for Thrombosis.TV, joined now by Dr. Dimitriy Arioli. Thank you, sir, for coming and spending a few minutes with us. So you've got a piece of research, new oral anticoagulants in patients affected by high-risk atrial fibrillation with history of intracranial hemorrhage. Before we get into your work, let's identify who these patients are.
They are really frail patients with a history of previous intracranial hemorrhage. That means that they already had the worst complication of anticoagulation or antithrombotic therapy. So they are patients that some years ago we really didn't know what to do. Okay, so this is also a hope for a very difficult patient.
Okay, so you just finished an oral presentation here. Tell us about the background of the study that you've conducted.
The background were some few data from retrospective studies. They talked about the risk of recurrence in this patient if we start the therapy with vitamin K antagonist. That was the only drug that we had until some years ago. So we had data that were a bit disappointing, because we didn't know really if restarting therapy could be good or bad for this patient.
So what were the key findings?
The key findings were that we can treat the patient probably with good result with the new drug, but we have to know that we will pay a price in bleeding events. Bleeding, not intracranial bleeding, so bleeding that we can treat in our hospital. This patient could have a problem with new drugs, but it's probably they will not have any other intracranial events, and that's what we really want.
And what would you treat this patient with?
Which we treated with NOACs, so the bigatran, rivaroxaban or apixaban. We used in quite a lot of these patients reduced dose because they have a problem with their kidney, because they were old. The middle age, the median age was 17, 18 years old, and the creatine clearance was 60. So they are not the patient we found in the clinical study. They are completely different, but if we do our best with a new drug, we can treat them too with good results. What
would you do next in this research?
Probably we'll try to dose the drug in a patient and see if the plasma concentration and that of that we found in the clinical study, or if they are higher. And other thing is that probably in my research, we just look after the patient from a single center. We wanted to do the same in different centers, so in different hospitals from my country, at least 6 hospitals. And with 6 hospitals, we can have an answer for a big issue.
Doctor, thank you for your time and sharing your work with us. We appreciate it.
Thank you very much, and I hope to be here next Congress.
Okay, keep us posted,
with new results.
Okay.
Okay, bye.